In this episode of the ASN Kidney News podcast, ASN speaks with Michelle Josephson, chair of the ASN Transplant Advisory Group, and William Applegate, lobbyist for the American Society of Transplantation. In recognition of World Kidney Day 2012, they speak about immunosuppressive drugs and legislation to extend anti-rejection drug therapy.
Dr. Josephson, why do patients need to take immunosuppressive drugs?
It really has to do with our immune system and basically how our immune system recognizes self and other. And so when patients get a transplant, that tissue is really seen as foreign, as other, and our immune system is really very good at realizing that this is a foreign entity and consequently mounts quite a response. Both the T cells and B cells are directed against the graft, and rejection ensues, and the kidney graft, the transplanted, is then destroyed. And so without the immunosuppression, without the ability to control our immune system, naturally our immune system is going to just simply destroy the transplant.
So this is a lifetime obligation that if someone has a transplant, they're going to need immunosuppressive drug coverage for the rest of their lives.
Absolutely. And I just want to sort of confine my remarks to kidney because there are other situations, actually sometimes liver transplant patients can come off immunosuppression, but that's really some specific issues that I don't think we want to get into in this forum. But anyone who has a kidney transplant, for the life of that kidney transplant, they absolutely need to take immunosuppression. Otherwise, they really do risk rejecting their kidney transplant, and unfortunately, I've seen it happen.
Given this background, Mr. Applegate, why did Congress initially provide coverage for 1 year and then extend it for 3 years? What's the rationale behind the 3-year cap?
Initially, Congress was looking to cover the benefit within transplantation, and I think immunosuppression, unfortunately, is viewed largely as an afterthought. And Dr. Josephson just outlined, it was missed by many. So they then went into an incremental mode, and I think it was largely based, as so many things are in Congress, it became a financial decision and what the appetite, if you will, of Congress was. And so they took, I guess, what they would consider to be baby steps in terms of coverages. And this has been something that's been on the agenda of at least the American Society of Transplantation and a large part of the renal community as something that crawled back from for a long time, and certainly in the last 10 years or 5 sessions of Congress, it's been a top-tier item. And, of course, it's very difficult to find anybody of the 535 members of Congress to tell you that this is a bad idea. I mean, the discussions are largely based around economics. And, the transplant community, we feel like the economics are actually, on our side when you start looking at dialysis and the costs there. And the fact that coverage was set in stone early on. But as we all know, nothing is ever easy, and trying to rearrange those policies to make it a little more cost-effective, cost-efficient, it's been a difficult battle.
What are some of the other examples of incremental decision-making by Congress where they make an initial decision and then over time they extend coverage?
I think in imaging, there's been back and forth in terms of how comprehensive the coverages have been, and there are many benefits that are covered, then they back away, they cut that coverage. Once they start cutting, it's very difficult, of course, to regain the initial reimbursement. There aren't a lot of examples similar to this one.
From perhaps an ethical perspective, can you just sort of walk us through the difference from a patient perspective if they do not receive the continued coverage and they end up losing their transplantation, sort of what that experience is like from a clinical perspective and an ethical perspective?
It's devastating to have gone through a kidney transplant operation and to be taking immunosuppression, have a good functioning organ, and then all of a sudden to find that you don't have the coverage to continue taking your medication. And sometimes to be put in a position of having to make a choice between getting things for the family, providing for their family, and potentially using money that the family might need or might use to buy immunosuppression. I have seen individuals faced with this dilemma who won't talk to their family but make the decision to try to start cutting back on immunosuppression. And because they're either embarrassed or don't want to put their family in that position, making a choice for them. and to start to cut back or even stop getting their medication, and then to come in with an increase in creatinine and kidney dysfunction and biopsy which shows rejection and sometimes irreversible rejection. And it's devastating to that individual, but it's also devastating to their whole family. And then they have to return to dialysis. And that was not necessary if the kidney was working and could have continued to work for quite some time. Now, there's several consequences of that, certainly in terms of, their life and their well-being, but also in terms of their longevity, because we know that patients who are on dialysis, their survival is not as good as patients who have kidney transplants. And what's even more concerning is that patients who return to dialysis, their survival may be even shorter than patients who never had a transplant. So losing a kidney transplant is psychologically devastating. It has major consequences in terms of the individual's health. The truth is that on a year-to-year basis, it costs the system less for them to continue with the kidney transplant than it does for that individual to return to dialysis, which is a more expensive modality.
Why does a patient who has a failed transplant, when they return to dialysis, why are their outcomes likely to be worse?
Well, I don't know that we know absolutely why their outcomes are worse. It has been looked at, and that does seem to be the case. Much of why individuals who are on dialysis die are from cardiovascular and complications and infectious disease complications, and it may just be that having been on such high levels of immunosuppression and having them cut off so quickly has dire consequences. But I don't know that I know the answer to that question 100%.
One more question in this area, and then I'd like to shift back to some of the policy-related issues. What are the sort of health disparities implications of the current policy that if Medicare is only going to cover the immunosuppressive drugs for 3 years, how are those choices made in terms of a person's economic status?
Oh, I think that's a very good point. I think it does affect different individuals in our society very differently. This policy does affect individuals who have limited coverage much more so than individuals who might have private insurance that continues to cover or have other resources in the family. And this lack of coverage probably does have health disparities implications because those who cannot manage the system quite as well, either because of socioeconomic consequences or because of their educational ability to figure out resources and to figure out how to manage the system, are going to find themselves with bigger problems.
So, Mr. Applegate, you had mentioned the Congressional Budget Office in their role in scoring proposed legislation. I have two related questions. The first is, can you provide our audience with a thumbnail sketch of sort of CBO and how it operates? And then the second question is just to sort of walk us through the last couple of years in efforts to get this legislation scored in a way that it makes sense from an economic perspective.
The most basic way to explain the Congressional Budget Office is, in theory, it is a nonpartisan body that serves Congress to come up with cost estimates. And obviously everything, and particularly in this political environment, is very important to have as low a score as possible. Their job at CBO is to come up with the most statistically valid cost estimates back to Congress. And so the challenges really with CBO over the years have been back-end savings. That is to say, scoring preventative measures, treating something more cheaply up front, more cost-effectively up front, and what are the benefits on the back end. And so all the evidence supports that. I mean, when you look at end-of-life care and the fact that most dollars are spent there, that if you can treat something up front, obviously that's where you want to be. And certainly in this particular case with immunosuppression, that's always been the argument. And as Dr. Josephson was saying, I mean, if we can do this and get folks the immunosuppressive drugs they need, they will, in most cases, keep the kidney, and they won't wind up back on dialysis. And as they say, generally, we're looking at 4 times the cost for dialysis than if we just provided the immunosuppression up front. All of that said, so that's a long way of saying that CBO looks only at what it costs walking in the front door. So it's very difficult to get them rationale-wise to recognize in their scores the real savings. I guess the other issue there for Congress and how Congress uses those numbers is, we've got a Congress that's 435 members of the House are up for re-election every 2 years, and the Senate every 6. So you have members of Congress that also find it difficult to work with numbers beyond year or two. And so all of that is our challenge.
I'm struck by your horizon point that members of Congress are up for re-election either every 2 years or every 6 years, and so their time horizon for any savings is going to be very short. And my assumption is this sort of legislation, the time horizon has to be much longer. So how do you make that case to someone who's going to be up for re-election this year?
This might sound a little too Pollyannish or naive, but I mean, the fact of the matter is this is the right thing to do. And as lobbyists and advocates very much consider something like patient immunosuppressive coverage as what we would call a white hat issue. When members of Congress stick their necks out or put their full weight or political will behind something, it generally has to be drawn back to their home states, their congressional district, in the case of the House. And, what are they delivering back there? And there are a number of reasons why members of Congress become involved in things. And this in particular is a wonderful story. And from a press perspective, a media perspective, from a re-elect perspective of something that's very doable that they can get done, that is the argument. And, even making a general argument like that in most offices, they will tell you we have no problem with what you're saying and we absolutely would support it. And we want your transplant patients to get the immunosuppressive drugs that they need. And then it falls back into how do we make this fit financially into a bigger package without spilling over.
How does the United States in its policies related to immunosuppressive drug coverage compare to the rest of the world?
So I think that's a very important question to ask because, in fact, if you look around the world, there are a lot of examples of countries that we would consider in many ways similar to us who do provide lifelong coverage. Just coming to mind, I could think of Australia, Canada, UK, and there are many others. But unfortunately, we're not among that company.
So, Mr. Applegate, how does that argument play on Capitol Hill when you present them with articles and with data from other countries, and it shows that the United States is unique in the sense that it doesn't provide lifetime coverage? What's the reaction?
Well, we've been really pressing that point. The New England Journal of Medicine came out with a study not too long ago, an article that made that point precisely, that of all the industrialized nations, we are the only that does not provide immunosuppression. It's not lost to anybody on Capitol Hill, but it is not enough to carry the day. It certainly helped. Reporter Kevin Sachs of the New York Times has been covering transplants for the last probably 5 or 6 years, and has had a couple very good articles that discuss the economics of this, and it all helps. But again, we need a package, and we need members that are willing to really press this and get it on the president's desk. So we keep edging and nudging forward, but we are all scratching our heads and have been for some time, wondering why this isn't something that the stars don't align. We've run out of time. A couple of different, we've had the bill advancing, moving through committee. There's been hearings over the last 10 years on this, all very positive. And ultimately, Congress either runs out of time or most recently in the last session, as I said, it was in half of the package, but not in the final package. We've been convening lately meetings of all of our stakeholders on Capitol Hill. So this is Senators Durbin, Senator Cochran, Congressman Burgess in the House, Congressman Kind, Congressman Pete Stark, all of their staff are quite cooperative in terms of getting together. Honestly, it's very difficult to get that group of folks from Republicans and Democrats to agree to even meet and get in the same room together at times on issues, particularly healthcare reform. I mean, it's a lightning rod issue right now. The Democrats are trying to push forward, obviously, by 2014 and implementing most of the provisions. The Republicans in the House are certainly looking to repeal and kill as much of that as possible. And I'm generalizing, but I mean, that basically is where the two groups are coming from.
So you had mentioned meeting with the former administrator of the Centers for Medicare and Medicaid Services, Don Berwick. I'm just curious, since transplantation is less expensive than dialysis, Is CMS an advocate for lifetime coverage? And how do they fit into this discussion?
Like all folks in government, I mean, they're clear. This is not a decision that can be made by the regulatory agency. The discussions that we've had, both formally and informally, sure. I mean, they agree that it is more cost-effective to provide immunosuppression. And like I said, I didn't sit in the meetings between Congressman Burgess and Don Berwick, but we were assured from Burgess's staff that it was all very positive, and that he acknowledged that this is not a good way to run this part of CMS and the coverage business. So, if only it were that simple to have the agency agree and make the changes.
There's a fair amount of momentum right now. There was a recent editorial in the New England Journal of Medicine by Tonelli and Gill that really, I think, laid out both the economic arguments in favor of this legislation, but also the comparisons with the rest of the world. Thursday, March 8th is World Kidney Day. World Kidney Day is going to focus on issues around transplantation. If you could have a call to the kidney community, to the transplant community, and you could ask them to do one thing on World Kidney Day to advance this agenda, what would that be?
Contact your representatives, your senators, your congressmen. Let them know how important this is, and let your voice be heard, because this is just an incredibly crucial point that we need to get across.
This is far more cost-effective to provide immunosuppression. The patients of failed grafts are returning to dialysis. There are all sorts of complicated issues. To mention that they are aware of the fact that this is legislation that's been on the docket for the last 10 years, that has a lot of broad bipartisan support. And I think just urge their members, really, as Dr. Josephson said, to contact either Congressman Burgess's office or Congressman Tynes' office, Senator Durbin or Senator Cochran, and ask that they be co-sponsors.
So what we'll do, ASN, in terms of its role as being a participant in this important effort and being a member of the coalition and of the community, is obviously use the mechanisms that we have in sort of online pleas for our members to contact both their members of Congress as well as the sponsors of the legislation, urging them to continue to lead this fight and to really do what's best for the patients and ultimately what's best economically. So I just want to thank you both for today's discussion.
Thank you very much.
Thank you.
This podcast is copyrighted by the American Society of Nephrology. All rights reserved. All content in this podcast is for informational purposes only and is not intended to be medical advice. The information in this podcast should not be used during a medical emergency or for the diagnosis or treatment of any medical condition. Please consult your doctor or other qualified healthcare provider if you have any questions about any medical condition or before taking any drug, changing your diet, or commencing or discontinuing any course of treatment. Thank you for listening to this podcast of the American Society of Nephrology.